Good morning everybody. Today we are going to talk on the hip dislocation. In last class we have discussed about the SWF. Before that we have discussed about the pelvis. Somehow we know something, yes or no? Yes. Now today we are going to discuss about the hip joint. Now before going for this subject proper, you are supposed to tell us something about the hip joint. So essentially it is a ball and socket type of joint. So polyaxial. Polyaxial means what? Polyaxial means multiple axis. It has got freedom of movement in many directions. That is why I call it polyaxial. Two major ball and socket type of joints are there in your body are shoulder joint and a hip joint. But there is some basic difference between these two also from the stability point of view. Both of them are having your polyaxial, multiple axis. Polyaxial joints are mostly less stable. Stability point of view is less. Mobility point of view. So if I have to compromise, see, you cannot have both the things together. So certain joints are having less mobility, means stability is more. But here, mobility is more, but you have to compromise the stability as well. But comparing it between the two joints, shoulder joint and the hip joint, which is more stable?
Hip joint.
This is more stable. Why? Greater part of the
head is covered by the stomach.
That means body configuration also going to give us the stability because greater part of the ball is inside the socket. Basic thing, okay, understood. But how much? And this is not true in only position. Particularly it's called vulnerable position of the hip. One situation known as vulnerable position of the hip, just like vulnerable position of the shoulder. What is the vulnerable position of the shoulder? Abduction and externation. That means in this position, a simple thrust can cause dislocation or injury to the joint. That means you need minimum injury, minimum force to do so, damage to the joint. Basic thing is that minimum force to damage the joint because the position is vulnerable. The person is vulnerable, you are striking him from back, that is he is vulnerable position. But if you are confronting him from the front, probably you have to face the resistance. That is what I am talking actually. So exactly same thing applicable. The person who is in, you are attacking someone is attacking from the back is a vulnerable position. But you are coming from the front, then you have to face the resistance. Similarly to here. So this is a vulnerable position. In this position, what happens actually, force is less, damage is more. Damage is more. That is why it is called vulnerable position. 1 point. Number 2, what are the other, because before going to the joint properly, what are the other stabilizing things? What again provide the stability? Because stability is more important for the dislocation. More it is stable, less it is chances of your dislocation. That is the point. So what are the other contributory factors, but contributors for the providing stability? Before that, you have to talk about the ligament is coming here. Inner layer, one is your inside.
Yes.
But it is said in any of the position, 40% of the head is inside the septum.
Yes.
Any of the position. One. Number 2, that you know about the glenoidal labrum.
Yes.
So labrum is the fibrocartilage sort of thing, which is a ring around the acetabulum thing. So what is going to do? It increases the depth of this socket. Same is true for the shoulder joint also. You know the shoulder joint is very shallow type of joint. Cavity is very shallow. To some extent, the depth of this socket is being increased by this labrum. Same is true for the shoulder joint and this also. Take a 1 point. Number 2, the capsule. Capsule on you have to come with the ligaments. So you have to come from the inner. So from the inner point of view, there the joint is inside the joint. The lady joint to some extent is stable. The stability is also being contributed by the labrum. Some extent it is also increasing depth of this. This also the inside the joint. Head is more inside the joint. Fibrocartilage ring. Number 3 is the capsule. So you know the capsule attachment is very not same with that anterior to posterior. So a capsule is basically condensation fibrous tissue. Basically, and ligaments are actually basically type of a capsule also. Only when there is more concentration, then it is your ligaments. So capsules are attached where? Where is the attachment of the capsule? One is from the anteriorly and posteriorly, these are different. So anteriorly, if you will find that this is attached to the what? This is what is the line known as?
Intertocondic line.
Intertocondic line. So capsule is a structure which is holding the soft tissue contributor to provide the stability. So one attachment is from the ring, acetabular ring. Another towards the head, towards the neck. So in the anterior side you will find this intertrochanteric ridge. And posteriorly it is called intertrochanteric crest. The crest is more prominent, less prominent. So anteriorly it is attached to the intertrochanteric line, but not same is true for the posterior side. Posteriorly it is not attached to here. It is a bit shorter. It is almost half inch shorter. So in tooth peg you will find the anterior part of the neck is more inside the capsule. Posteriorly it is not true. True. Yes or no? Yes. So and let us talk what happens to the capsule now. This capsule is attached here posteriorly and anteriorly it is attached here. After the attachment it reflects back along with the neck of the femur. This is called retinaculum. You do not have periosteum in the neck. That is why it is another inhibitory factor for union of the nerve. Yes? So unlike the other part of the bone, you will find the periosteum where you have the two layers. One layer is contributing for the osteoblastic activity, deeper layer, cellular layer. So you do not have this. That is the difference between these two. This is called periosteum. This periosteum is replaced by retinaculum. So retinaculum word is coming from retention. Who helps in retention is called retinaculum. Retention, it helps in retention. And along with this retinaculum, you have the retinacular ones coming from this external extracapsular ring, which is contributing there, is going towards the head, towards the neck. That is another part. That is one. Number two, what are the other stabilizers? There are two important ligaments, three important things basically. One is called iliofemoral ligament, said to be one of the strongest ligaments in your body. One point. This is also known as bigelois ligament. This is also known as Y ligament. Why is Y?
Shape is like
So the base is here, ligaments are coming here. So there is reversal. One is called femoral ligament, and another is from the back is the ischial tuberosity to the ischial tuberosity. So these are the three main important ligaments. So you have the labrum, you have the capsule attachment, then top of this you have the
three
ligaments, anteriorly two, posteriorly one. So these are the ligaments going to provide the stability. Besides these muscles and other things are always there, external rotator, small internal rotator, other muscles are also there to provide the stability. This is one point. Now let us talk about the dislocation now. What is dislocation, how it happens, and what is the mode of injury. What is the commonest injury you get? Hip dislocation. Almost more than 90%. Then you have central type, anterior. These are less. I sent another list one. So what is the mode of injury? The mode of injury is different. What is more important to understand is then the dislocation depends upon the force or axis, which direction is coming one. Number two is the position of the head, hip at this moment of time. What is the position and what is the axis? The resultant depends upon this. The impact going to do the damage, where anteriorly or posteriorly or medially, depends upon all these things. Force working. So necessarily for posterior dislocation, force supposed to come from anterior. Then for the posterior, for anterior is supposed to come from back. And central type from the lateral side. These are the basic things. So since posterior dislocation is more common, let us talk about the posterior dislocation now. As you know, most of the time we encounter this thing in the dashboard injury. What is a dashboard injury?
The knee hits the car dash.
See, dashboard injury, see, person is sitting like this. At this moment of time. Most of the time they are cross-legged. So what is the position of the hip now?
Flexion, internal rotation.
Flexion,
Adduction.
adduction, to some extent they are internal rotation. So this is it. This is, as I said, this is one of the vulnerable position. This is the position of the person at the moment of time. If the force is coming from anterior side, push, so it is going to go. Now it depends upon how much doing the damage posteriorly we talk. So this is going to do this. Yes sir? It is going to out. While this out, what are the damage we will talk. Now what is the position of the hip? What is the attitude of the limb now?
Flexion, adduction, internal rotation.
Adduction,
Internal rotation.
But sometimes it may not be there. In what condition? What condition? This flexion, sir, what is the attitude of the limb in the anterior dislocation?
Flexion, abduction, external rotation.
Favor.
What about the flexion extension?
Flexion, abduction, external rotation.
Flexion, abduction, extension.
What is common between these two?
Flexion.
Why so? But the things are reversed. But one thing is common. Flexion. Why it is so? The similar thing. So this is the head is now anterior, head is now posterior. Posterior flexion, adduction, internal. Then if it is reversing is happening, why attitude is not reversed?
So because of
the muscle push,
Strong flexors.
Because of the iliofemoral ligament. It is because of the iliofemoral ligament. Now, one time of concept, atypical reduction, atypical dislocation. What is atypical dislocation? Where you do not get flexion. So in this situation, there may be tear or injury to the iliofemoral ligament. So in the iliofemoral, so sometimes very rarely you may get, typically supposed to get it like this.
Yes.
But in situation when the patient is extended, in posterior dislocation, flexion to there, adduction in other typically is not there. So this is called atypical dislocation. This is mostly commonly seen in case of your injury to the iliofemoral ligament. That is important. That is why it is interesting that flexion is common in both the conditions, whereas the dislocation is reverse. So one thing is common, that is your flexion, and that is because of the iliofemoral ligament. So if it is torn, then you do not get this typical attitude. So in this situation, it is called atypical dislocation. So they do not have a mindset. They in a dashboard injury, you are not getting it, you do not get it. You make it. You make it. That is the point. So sometimes it's a rare one, but even then there is a possibility to get it. ठीक है sir? That is one point. Now next one is that depending upon the position of it is going to be out. Where it is hitting? Posterior acetabular, posterior part of the acetabular. So it depends upon now. There are two things are in the impact of the force. One is your head, which is impacting with another hard surface. Now hard or soft, it depends upon the position of the head. Now what will be damage to this part? Tell me. Now it is happening, it is going out. So when it is going out, it is hitting on this. So there you have gradients of your injury to the acetabular, as well as there is a possibility to injury to the head. Two things are there. Now what is the factors? How you determine what is the extent of injury? So there is another classification, yes. Thompson-Aston classification, you know always. The Thompson-Aston classification, what it says, that in type 1, what is happening? Type 1, see, it all depends upon it. There is an interesting thing here. So if my head is almost like this, ठीक है sir? One point. Number 2, if my head is more in adduction, impact force is same, but resultant injury may not be same. Why so? Why so? So it is basically, see, if it more in adduction, it is like this. More in adduction, more his head is out. So more his head is out, it is mostly in the soft tissue now. So if it is going out, it will cause what? Damage to the soft tissue only, not the acetabular. Yes, sir? Now if it is going like this, there may be injury to the lip.
Yes.
So this is type 1, this is type 2. So type 2 means one single fragment. And type 3, it may be committed. This part may be committed. Yes, sir? And time for if it is abduction sort of thing. So more part of the head is inside. So if the force is coming like this, it may cause the acetabular fracture. So this is a important thing. See, depending upon the position of the head, the injury in the posterior part will be depend on this. This is very clear. Now, so more in adduction, more the head is out, easily coming out. This is limited to soft tissue only. Now, if it is like this, so it will cause the lip. Big fragment may come out. It may go for combination. But sometimes if it is like this, it may cause the acetabular fracture. So all dependent upon this fracture. It is clear? So that is why you have a classification known as Thompson and Epstein classification depending upon the injury of the posterior structures. So it may be only limiting to only soft tissue, or sometimes a very small fragments of periphery lip may need to do with the surgery. Big fragment, combination, etc. ठीक है sir? Now, if it is going out, it is also causing the damage, and interestingly also there is an important structure lying behind. Here. What is sciatic? No. Coming out like this. So it is going to hit. So there may be consequent injury to the sciatic nerve. Consequent injury to the sciatic. So damage is here and damage is here. ठीक है sir? All depends upon the position of the head and the force. ठीक है sir? Now, since other part is also in infection, there is a possibility to injury to this also. So what are the gradient now? Another cause of Pepin's classification. You know it?
Yes.
So this is also under understanding. See, the impact is going like this. So it is like this. If it is like this, so it may be below the phobia. So below the phobia is one. It is called Pepin's classification, type 1. Where the fracture of the head may take place. Head may take place below the phobia. So below the phobia is not very serious thing because this is not going to take the bear weight. Weight bearing part is mostly superior part. ठीक है sir? One point. ठीक है sir? Sometimes it may be injuring to the weight bearing area. This is more damaging. So it is very important that you have to reconstruct and do the reconstruction. Otherwise, patient cannot work.
Yes.
Because this part weight bearing zone is damaged. 1, 2. Sometimes they may fracture the neck. Yes, sometimes associated with fracture of the neck. So you may have the variants of injury phobia, inferior, superior, then acetabular fracture. So all these things may combine together. So it is also dependent upon the same thing. So that is why it is always important to look for the CT scan. Subsequently, after CT scan is more important to do it after reduction rather than before reduction. Before reduction, most of the time you clinical diagnose it. Yes or no?
Yes, sir.
Or otherwise, even you can simple X-ray can tell you. But after reduction, CT scan is more important. No. Yes, sir. Now this is happening. Clinical test is done, X-ray is done, everything is done. Now what next? Reduction technique. Okay. We will go for the reduction now. So damage you all know. So while the patient is coming to you, clinical features are there. Attitude is there.
Flexion.
Equally, one should also look for the what? What?
DNVS.
Attitude.
DNVS. DNVS.
Basically, you look for the sciatic nerve injury. So it is always paramount important to document the extent of injury. Otherwise, it will be another consequence that the patient is developing during the time of treatment or during the time of injury. So the documentation part is very important for your point of view also. ठीक है sir? Now this thing is done. Patient is stable. Now this is the emergency situation. So one should try to reduce it as early as possible. The consequence because of this first subsequent result depends upon how early we could able to reduce it back to the position. More the head is out, more the chance of damage. More the chance of damage, you have so many consequences of your AVN, other things, osteoarthritis, whatever it may be. So all dependent upon how early we could able to reduce it. Now what are the techniques? What technique we used to follow? Most of the time? Cockers? Soldier. What thing was
Soldier.
No good. So,
Alice-
you got
Alice
the
method,
Alice
sir.
method. So most of the time, patient is under anesthesia on the floor. On floor. What you call? Patient under anesthesia on floor. So what you are going to do? So this is head is lying like this. You try to do the flexion of the hip and also flexion of the knee. One person that hold it.
Pelvis.
One assistant is going to hold it. Anterior relaxation is stabilize itself. Another surgeon will be doing the reduction like this. Yes, sir. It will reduce like this. So you do little bit of your rotation. Sometimes may be helpful. Otherwise, you have to give an axial pull. So surgeon is here. Now he is pulling it. Yes, sir. So how will you know the reduction is taking place?
Clock.
Clock. One clock, and after that he will have a freedom of movement. What next thing we are going to do? Checking. You have to push it back again. See how easily going out or not. Easily going means more dangerous, unstable. So in this situation, after reduction, you are supposed to give a skeletal traction and maintain it. Otherwise, it may go back. 1 point. Number 2 point is that it is coming reduced, but not going easily. There is to some extent stable. So you may not give for skeletal traction, you may give a inflation. Good situation. Number 3 situation, where you are unable to do the reduction. It may happen sometimes. Now tell me what are the causes?
Soft tissue interposition.
What are the causes?
Fragment inside the
There are two mostly two things. One is soft tissue, one is bone. What is called buttonholing? Have you heard the term buttonholing? So button is like, so if you pull the button like this, it cannot come out. Yes or no? It will not come out. But if you do the maneuver, then it can come out. Same thing is true. So what is buttonholing? So buttonholing is basically the capsule and also the external rotators, which is holding the neck like this. You are not allowed to come out. One soft, there are few. One is soft tissue, another is your bony. Soft tissue mostly timely bony. Your buttonholing. 1 point. Number 2, sometimes sciatic nerve may come in between here in this area. You may not allow it to come. Number 2. Number 2, infolding of the labrum. So it is occupying the cavity. So you are not allowing it to go inside. See? Then number 4 is a monobony fibrils, which is coming in between, which is interfering. So you have so many things to do. So in this situation, it is important to do for the open reduction and do the correction. Usually, it is not necessary, but if it is unable to do the close reduction, one should do a open reduction and reduce it. Okay, sir? So these are the 3 situations. So 1 point that you unable to do the reduction, the causes are like this: soft tissue or bony. Okay, sir? If it fails, you should go. Is there any more technique you know by which? One is your Alice technique, another is your Bigelow's technique. Bigelow technique, you do the reverse of the maneuver. Reverse. You have flexion, you do the extension. You have adduction, you have the adduction. You have to do internal rotation, you do external rotation now. So these are the techniques of the Bigelow's technique. Bigelow is a very interesting history. You know Bigelow's concept? No. He was there in the casualty. He did a reductions of the posterior dislocation in the casualty itself. Now his professor was there in the first floor. So he thought that he become to know it will be difficult for him to face why he have done the reduction. So what he did, he dislocated and sent the patient to the first floor, to the professor. Professor tried but failed. Unable to do reduction. Then he called back and he did the reduction. That is called Bigelow's technique. Bigelow's a very interesting history. So Bigelow's technique. So that is how the Bigelow's concept is called. We have the reverse. Then other any another the point gravity is this. Now the Baltimore test is also there. With the help of the other is pull. Basically principles are same. You are giving the pull to the reduction. The concept is like this. So you may not. If you can do the stability test. Unstable, go for stand beam. Retraction. Then evaluation of the patient, subsequently the CT scan. CT scan. That is very important. Otherwise, it may come. Now, what next? What next? This is the important time to go for a CT scan here. The reduction, not essentially reduction, but it is a congruent reduction is more important. That the uniformity of the cavity should be there in the X-ray. Sometimes small fragments of the bone may be lying inside the two layers. So which is going to do the damage in the long term. So in these situations, the X-ray is not going to help you to know it better. So it is always going to do the CT scan. It is better to know where small fragments will be there. So this is not a good ideal situation. One point. And also to know about the integrity of the posterior, because you know this in the posterior part is damaged. Be it acetabulum beam or the floor itself, whatever it might be. Yes, sir? So if the fragments are coming in position after reduction, acceptable position, you can consider to take the patient for conservative treatment. Conservative treatment. Two things I am talking. One, congruent reduction. That means nothing is inside. Reduction is very good, otherwise fine. 1 point. Then that is, you can go for conservative treatment. But another point is that what about the posterior structure, posterior acetabulum? So there may be injury to the, as I said, it may be big fragment or sometime or big fragment may be there. Big fragment may be there. Yes or no?
Yes.
So 1 point. Number 2 point, after reduction, what is the situation? You have to evaluate it. After reduction, what is the situation? Reduce is there. We clinically also know, you know, because patient is now free, length is maintained, deformity is corrected. A patient, you can have a pre-normal movement. This indicates clinically that the reduction is there. But whether it is congruent one, number 1. Number 2, whatever this posterior acetabulum part, are the fragments are in good acceptable position or no? If it is not acceptable position, then you have to take the patient for operation subsequently for repair of the posterior structure. Yes, sir? Yes. So that is very important. So subsequently, you have to evaluate the patients with the CT scan, congruent reduction, nothing is there, everything is fine, forget it. Posterior acetabulum is fractured, part is fractured, fragments are lying here and there, you have to do a good reduction and fixation. But ideally this part is done mostly then secondary. You allow the inflammation to settle. It is a very traumatic situation. So it should be settled, edema, profuse bleeding is there. So you have to, meanwhile you have to optimize the patient. Make it fit for another surgery. So it is ideal to go for the, usually said, this is secondary time is the best time to go for the repair process. So you have to, again, you have to go for, now, again post-operative, post manipulation, what protocol? Protocol all depends upon degree of injury. In a situation where only soft tissue injury, you can mobilize the patient early. But if there is a bony injury, you will have to take long time. So this is not universal. The post-reduction protocols are not universal. It is tailor-made. Tailor-made. Tailor-made means depending upon the only soft tissue is there, you can mobilize the patient very early. But if there is fracture is there, you have to take rest for the union. Or even in certain situations, you go for operative treatment also. So this is not a universal thing that you allow the patient to work or whatever it might be, or confine the patient for a long time unjudiciously. So it all depends upon the degree of injury. Then you have to think. So all these things will come with the post-manipulation CT scan most of the time. So post-manipulation CT scan will tell us what is the extent of injury, what is the fragment's position. If everything is fine in normal position, we are happy. But if the fragments are not in position, there is a potential cause of the instability. So you have to address. So you have to go for the. I have already discussed about the cellular reconstruction, particularly in this situation. So you have to repair it and fix it. So that is the. What are the complications you used to encounter in this situation? No, acute and chronic. Acute and late. What is the acute? Acute is mostly sciatic nerve injury, profuse bleeding. So if there is a posterior, it is mostly sciatic nerve. If it is an anterior type, it is mostly
Femoral.
femoral. So you have to educate. And in long run, what? AVN.
AVN.
Sometimes AVN is very common. Number two is the osteoarthritis. Osteoarthritis here. So these things are there in the complication. So in nutshell, this is your hip. And again another, dislocation. One is your anterior dislocation, which is what are different types?
Operator type and still type.
One is going up. No, skill posterior
Is
type.
pivot type.
But basically, key sometimes what is the mode of injury there?
Class.
Mode of injury, mode of injury reverse. So, suppose if force is coming from there, suppose the patient is like this, his abduction like this, and there is fall or something is hitting from the back. So he is falling like this. Yeah? So that will be, so if he is in abduction and the force is coming from any hard object is falling, then it will go like this. So operator type is very difficult to reduce sometimes. It is locked here. Sometimes patients are also coming very late because sometimes we give a stability and patient can walk around. You can make late presentation sometimes. Then here the patient is almost coming sometime late because it is locked here. He is stable, so he can walk even with some difficulties, but he can walk. Unlike the posterior dislocation. Sometimes again it may go for the pubic tape. That is true. So the techniques are almost same with that of POD. So sometimes it is a difficult situation to reduce. Then you may need to go for ventilation somewhere. A bit difficult situation. Central pipe again coming from the lateral side, compacting. So this is mainly considered as a acetabulum flexure. So they are again to concept conservative, operative. Sometimes we have to get skeletal traction to pull it back. Resultant one here, another this side, so the resultant force will be coming it out. So that is one. Otherwise you may need to go for a reconstruction sometime. So that is one. So most of the time we encounter the posterior. So you must be very clear about the posterior dislocation, what is the mode of injury, what is the position, what is the damage, what are the techniques by which, where you are going to fail, and what to do with the fail. If it pass also, what to do subsequently, and after that how to continue the post manipulation. They dependent upon the degree of injury. So all these things are important and you have to practice.
Bueno,